Our next speaker in the Young Physician Forum is Dr. Swandika, Senior Registrar in Internal Medicine at National Hospital, Kandy, and she'll be talking to us about eosinophilia, a hidden pearl in blood count. Over to you, Swandika, to start the presentation.
Thank you, sir. Good afternoon, dear distinguished guests and my dear colleagues. First of all, I would like to thank the Ceylon College of Physicians for giving me this opportunity to present in this prestigious forum. My topic today is eosinophilia, a hidden pearl in full blood count. The reason I selected this topic is that even though we encounter with patients who are having eosinophilia in our day-to-day practice, eosinophilia is an insufficiently and infrequently addressed area which is important. So before starting my presentation, I would like to bring upon 3 case scenarios. The first patient is Mrs. X, a 35-year-old female who was found to have an eosinophil count of 900 per microliter at a routine medical checkup. The second patient is Mr. A, a 58-year-old male presenting with a skin rash over flexural areas, visual blurring and chest pain along with an eosinophil count of 1800 per microliter. And the third patient is Mrs. Y, a 44-year-old female who was found to have an eosinophil count of 1600 per microliter at a routine medical checkup. So how will you evaluate and manage each of these patients? I hope that all of you will be able to find accurate answers for these scenarios by the end of my presentation. The content of my talk includes the terminology, causes of eosinophilia, an approach to a patient with eosinophilia, and finally, overview of management. So going back to history, the eosinophil was first described by Sir Paul Ehrlich, who was born in Germany. In 1879, he defined and named the eosinophil based on cell morphology, physiology, and pathology. As you all know, eosinophils are granulocytic leukocytes produced in bone marrow with the help of cytokines, predominantly interleukin 3, 5, and GM-CSF. They make up 1% to 6% of total white cell count, and the normal count in peripheral blood varies from 0.05 to 0.5 into 10 to the power of 9 per liter. I hope you can appreciate the typical appearance of an eosinophil in this picture. So there's a nucleus, a cytoplasm, secretory glands surrounded by a membrane. With regard to functions of eosinophils in human body, they're helpful in maintaining host defense mechanisms, maintaining metabolic homeostasis, immune response regulation, tissue remodeling and repair. And they are also useful in maintaining humoral immunity and in cell activation. So in healthy or normal individuals, eosinophils are only found in lymphoid organs, mucosa of the gastrointestinal tract, and the uterus. However, in pathological conditions, prolonged activation of eosinophils leads to migration of these eosinophils to other tissues like the skin, heart, and lungs, inducing thrombosis and fibrosis, and the end result being end organ damage. What is eosinophilia? So eosinophilia is defined as an absolute eosinophil count of 500 or more per microliter. So there are 3 degrees as mild, moderate, and severe. Mild is when it's between 500 to 1500, and moderate is when it's between 1500 to 5000, and severe is defined when it exceeds 5000. And what is hypereosinophilia? Hypereosinophilia is defined as an eosinophil count of 1500 or more, persisting for at least 6 months with or without concomitant end organ damage. Moving on to causes of eosinophilia, causes can be categorized into 3. First entity is primary or clonal eosinophilia. The second subtype is secondary or reactive eosinophilia, which will be the highlight of my talk today. And finally, there's idiopathic eosinophilia. Primary or clonal eosinophilia is when eosinophils are part of the neoplastic clone. So there are several subtypes of primary eosinophilia, as you can see here. Out of them, the common subtypes are myeloid and leukoid neoplasms with rearrangement of several genes and chronic eosinophilic leukemia not otherwise specified. All the other entities are rare subtypes, and interestingly, systemic mastocytosis falls under this subcategory. Then secondary eosinophilia is when eosinophilia is secondary to some other systemic disease. As you can see here, there are several causes which I will be elaborating during my presentation. Allergic disorders are one such common cause for secondary eosinophilia. So as you all know, common allergic disorders like atopic dermatitis, asthma, and seasonal disorders like rhinitis and hay fever are associated with eosinophilia. So these diseases typically cause a cytokine-driven non-clonal eosinophilia, which is usually mild. But having said that, there were few case reports where asthma was associated with marked eosinophilia rather than mild. Then there are several dermatological causes associated with eosinophilia, like Wells syndrome, blistering diseases like bullous pemphigoid and pemphigus vulgaris, eosinophilic pustular folliculitis, angiolymphoid hyperplasia with eosinophilia, Kimura disease, and some other disorders of pregnancy. Wells syndrome or eosinophilic cellulitis is a recurring granulomatous dermatitis characterized by a sudden onset erythematous to edematous patches, as you can see in the picture here, the picture towards the right, that rapidly evolve to morphea-like slate blue plaques later on. So these patients have a typical histologic appearance of flame figures and peripheral eosinophilia. I hope you can appreciate a typical flame figure in the picture towards the left. Flame figures are collagen coated with eosinophils. And then there's another entity called Kimura disease, which is a chronic inflammatory disorder of unknown etiology. These patients usually present with painless lymphadenopathy and subcutaneous masses, predominantly in head and neck region, but these masses can occur elsewhere also. And this is associated with high IgE levels. And there are several drugs associated with eosinophilia, and symptoms can vary from asymptomatic to life-threatening. So as you can see here, penicillins and cephalosporins cause eosinophilia in asymptomatic patients. As you all know, non-steroidal anti-inflammatory drugs are known to be associated with pulmonary infiltrates and gastroenterocolitis. Again, NSAIDs with semisynthetic penicillins and cephalosporins are associated with interstitial nephritis, which is again a well-known entity with eosinophilia. Ranitidine cause eosinophilic myocarditis, semisynthetic penicillins and tetracyclines cause eosinophilic hepatitis, and hypersensitivity vasculitis is reported with allopurinol and phenytoin. Aspirin is well known to cause asthma and nasal polyps. L-tryptophan contaminant causes an entity called eosinophilia margia syndrome. And then there are several drugs causing DRESS like sulfasalazine, antiepileptics, and allopurinol. So DRESS, as you all know, is drug reaction with eosinophilia and systemic symptoms. I hope you can appreciate a typical maculopapular rash of a patient with DRESS, which I have taken from an NEJM article. So diagnosis of DRESS is based on the registrar scoring system. Then there are several infectious diseases associated with eosinophilia, which you all know very well. The common infections includes parasitic infections and fungal infections. With regards to gastrointestinal disorders, there are several primary eosinophilic disorders like primary eosinophilic esophagitis, gastritis, and colitis. I hope you can appreciate the typical ring circular endoscopic appearance of a patient with primary eosinophilic esophagitis in this diagram. And interestingly, chronic pancreatitis has also been reported to be associated with eosinophilia. The incidence is higher among autoimmune disease than non-autoimmune disease. Apart from these, inflammatory bowel disease and celiac disease also have been reported with eosinophilia. Moving on to vasculitis, the commonest type of vasculitis associated with eosinophilia, as the name implies, is eosinophilic granulomatosis and polyangiitis. So these patients present with allergic rhinitis, sinusitis, peripheral neuropathy, mononeuritis multiplex, skin lesions, and rarely with renal involvement, and diagnosis is confirmed by tissue biopsy. There are three main rheumatological diseases associated with eosinophilia. First is systemic lupus erythematosus, where eosinophilia is not uncommon. Then 3% of patients with rheumatoid arthritis have eosinophilia. And there's another entity called eosinophilic fasciitis or Schulman's disease, which is a rare scleroderma-like immune-mediated syndrome where patients present with painful swelling and thickening of skin and soft tissues of the limb and trunk. So this is associated with hypergammaglobulinemia and high ESR. Then peripheral blood eosinophilia has been reported in several respiratory diseases like glomerular disease, tropical pulmonary eosinophilia, allergic bronchopulmonary aspergillosis, sarcoidosis, and acute and chronic eosinophilic pneumonia. The diagnosis is based on the typical history, the typical radiological appearance, along with alveolar eosinophilia, which is defined at least of 25% eosinophils on bronchoalveolar lavage. Then there are several neoplastic diseases associated with secondary non-clonal eosinophilia, including solid tumors, lymphoproliferative disorders, and lymphocytic variant hypereosinophilic syndrome. The prevalence of eosinophilia in solid tumors varies between 0.5 to 7%. This is more seen in advanced and metastatic disease rather than in early stages. So when a patient is presenting with unexplained eosinophilia, it's very important to exclude an underlying occult malignancy. Then the prevalence of eosinophilia in Hodgkin lymphoma is 15%, whereas in non-Hodgkin, it can vary from 2% to 20%. And interestingly, the prevalence is higher in T-cell than B-cell lymphomas. And reactive eosinophilia has been reported in patients with acute lymphoblastic leukemia as well. And in some patients with lymphocytic variant hypereosinophilic syndrome, a secondary reactive eosinophilia has been reported without overt lymphoproliferative disease. So I have mentioned a lot of systemic secondary causes. Apart from them, there are several other miscellaneous causes associated with eosinophilia. One such cause is atheroembolic disease, which occurs following cholesterol microembolization. So these patients usually have a transient eosinophilia, mainly in the acute phase of the illness, and diagnosis is made by biopsy of the affected organ. Then graft versus host disease is also associated with eosinophilia. So this occurs secondary to bone marrow transplant, even though the mechanism remains unclear. Then there's another interesting entity called the Gleisch syndrome, episodic angioedema with eosinophilia. So as the name implies, this is characterized by episodic angioedema associated with eosinophilia. So this resolves spontaneously without therapy, but there are some cases where these patients require corticosteroids. So these patients have raised IgM levels, but in contrast to hereditary angioedema, their C1 esterase level is usually normal. And Gleisch syndrome is not usually associated with end organ damage. But having said that, there was a case report where a patient with Gleisch syndrome led and developed endomyocardial fibrosis. Then there are several disorders of immune regulation associated with eosinophilia, mainly seen in the pediatric age group. As you can see here, common ones are hyper-IgE syndrome, DUC8 deficiency, and PGM3 deficiency. So all these conditions are associated with high IgE levels. I have discussed a lot of causes of secondary eosinophilia. So apart from those, there are other causes like hereditary eosinophilia, IgG4-related disease, and also endocrine causes like Addison's disease associated with eosinophilia. Then I've already discussed primary and secondary eosinophilia. The third entity was idiopathic eosinophilia. Idiopathic eosinophilia is defined as an eosinophil count of 1,500 or more and without any underlying primary or secondary cause. Interestingly, hypereosinophilic syndrome also falls under this category. So hypereosinophilic syndrome is defined as an absolute eosinophil count of 1,500 or more per microliter on 2 occasions, at least 1 month apart, persisting for at least 6 months, along with concomitant organ damage secondary to eosinophilia. So there are 6 variants of hypereosinophilic syndrome. First variant is a myeloproliferative variant. These patients usually have hepatomegaly and splenomegaly, and they have anemia, thrombocytopenia, along with high vitamin B12 levels. And interestingly, they are usually resistant to glucocorticoids. The second variant is the T lymphocytic variant. These patients usually present with skin and subcutaneous tissue involvement. Then the third entity is familial, which is usually autosomal dominant. There's another entity called idiopathic. So 75% cases of hypereosinophilic syndrome falls under this category. Then there's this organ-restricted subtype where only one organ is involved. And then there's a specific or defined syndromes with hypereosinophilic syndrome. So as you can see in this picture, hypereosinophilic syndrome can affect almost all the organs of the body. Ocular manifestations results from microemboli and local thrombosis causing blurred vision. Cardiac disease can vary from myocarditis to thrombus formation. Pulmonary disease involves fibrosis and pulmonary emboli. It can affect the vasculature leading to thrombotic complications. Neurological disease involves stroke, TIA, encephalopathy, and peripheral neuropathy. Skin disease can vary from eczema, erythroderma, lichenification, dermographism, recurrent urticaria, and angioedema to mucosal ulcers. And it can affect any part of the gastrointestinal tract, causing gastritis, enteritis, colitis, hepatitis, and even cholangitis. So how will you evaluate a patient with eosinophilia? Evaluation should be based on finding an underlying cause and concomitantly assessing eosinophil-mediated end-organ damage. So as in any other case, it's important to proceed with history, examination, and investigations. Important points in the history includes the history of skin rashes, episodic facial swelling suggestive of Gleisch syndrome, constitutional symptoms, cardiorespiratory, gastrointestinal symptoms, features of connective tissue disease. A thorough allergic history is important, a travel history, contact with pet dogs if toxocarea is suspected, a contact history or family history if scabies is thought of. A detailed dietary history is mandatory, including food allergy and consumption of raw food. Drug history is very important because several drugs are known to be associated with eosinophilia, and also in patients with long-term immunosuppressives, those patients are more prone to get parasitic infections like strongyloides hyperinfection. Occupational history is also very important. Strongyloides is more common among the mining population and ascariasis among slaughterhouse workers. So when examining these patients, if an underlying parasitic infection is thought of, it's very important to comment on the general hygiene and temperature. A thorough skin examination is important. Lymph nodes should be palpated. Signs of vasculitis and peripheral ischemia should be looked for. A thorough respiratory system examination, looking for an underlying respiratory cause. Palpating the abdomen, looking for hepatomegaly and splenomegaly. Cardiovascular system examination to exclude evidence of myocarditis. And CNS examination targeting for vision, peripheral neuropathy, and evidence of stroke. How will you investigate a patient with eosinophilia? So in all cases, the first thing is to repeat the complete blood count with the differential count to confirm the presence of eosinophilia. So once it's confirmed, the next investigations would be a blood picture, renal and liver functions, inflammatory markers, serum LDH, and vitamin B12 assays. So vitamin B12 assays are important because, as I already mentioned, patients with the myeloproliferative variant of hypereosinophilic syndrome have high vitamin B12 assays. So if a patient is asymptomatic and otherwise healthy with mild eosinophilia, further testing might not be indicated. But if a patient is having systemic symptoms or an eosinophil count above 1,500 per microliter, those patients should be aggressively evaluated for a secondary cause. So if an allergic etiology is thought of, serum total and allergen-specific IgE levels should be done, skin prick testing, and if a non-allergic dermatological cause is thought of, skin biopsy would be helpful. In infectious diseases, relevant stool samples, serology, and viral serology. And if a gastrointestinal cause is suspected, relevant endoscopies, serum amylase, tissue transglutaminase antibodies. And in patients with connective tissue disease, relevant antibodies like AMA and rheumatoid factor, in vasculitis, ANCA, and relevant viral serologies. In suspected respiratory cases, appropriate imaging, bronchoscopy with bronchoalveolar lavage. And if a malignancy is suspected, appropriate imaging and tissue biopsy, peripheral blood T-cell immunophenotyping, and other miscellaneous causes should be evaluated accordingly. So secondary or reactive eosinophilia should be confirmed, excluded, and treated at an early stage. So if a patient is having an eosinophil count above 1,500 per microliter, without any obvious underlying cause, the next step is to exclude a hematological neoplasm with clonal eosinophilia. So as you can see in this slide, if a patient is having an eosinophil count above 1,500 without any underlying obvious cause, the next step is to go ahead with a peripheral blood analysis for PDGFRA by FISH or nested RT-PCR, looking for a lymphoproliferative disorder. If that is negative, the next step is to go ahead with a serum mast cell tryptase to exclude chronic eosinophilic leukemia and systemic mastocytosis. So if those are negative, then invasive tests are recommended like bone marrow aspirate, trephine biopsy, and cytogenic analysis. And further evaluation depends on the results of these investigations. So in all patients with eosinophilia, it's very important to assess eosinophil-mediated end-organ damage. So in that case, a thorough cardiac assessment and a pulmonary assessment is mandatory. Finally, a bit on treatment of eosinophilia. So I have categorized it into four. First subtype is emergency treatment, irrespective of the cause. Second entity is treatment of primary or clonal eosinophilia. Then a bit on treatment of secondary eosinophilia. And finally, treatment of idiopathic eosinophilia and hypereosinophilic syndrome. So with regards to emergency treatment, there's no absolute eosinophil level to start treatment in asymptomatic patients because the absolute eosinophil count does not correlate with the risk of end organ damage. So if a patient is not having organ damage, irrespective of the cause, whether it's primary, secondary, or idiopathic, emergency treatment is not recommended. But if a patient is having significant organ dysfunction secondary to eosinophil infiltration to other organs, then those patients require emergency treatment irrespective of the cause. So the drug of choice in an emergency setup would be high-dose corticosteroids. If a patient is having life-threatening organ involvement, the recommended drug is IV methylprednisolone given at a dose of 1 milligram per kg per day. If there's no life-threatening organ involvement, the recommended drug would be oral prednisolone given at a high dose for 1 to 2 weeks and then tapered over the next 2 to 3 months. In extreme cases of eosinophilia, allopurinol is recommended concomitantly with steroids. So in patients who are not responding to steroids, a second-line agent should be considered. Moving on to treatment of primary or clonal eosinophilia, the exact drug depends on the exact type of primary or clonal eosinophilia. However, the recommended drugs are low-dose imatinib, standard-dose imatinib, sunitinib, sorafenib, ruxolitinib, and interestingly, there's a place for bone marrow transplant in these patients. So indications for hematopoietic stem cell transplantation in patients with primary or clonal eosinophilia includes patients with FGFR1 rearrangement, patients with chronic eosinophilic leukemia not otherwise specified, hypereosinophilic syndrome, refractory to therapy, and patients with progressive end-organ damage. Moving on to treatment of secondary eosinophilia, it's always treating the underlying cause. As an example, if a patient is having a parasitic infection, that should be treated. If it's a drug which is causing eosinophilia, that culprit drug should be withheld. If it's a respiratory cause, that should be treated. And apart from this, if a patient is having end-organ damage secondary to eosinophilia, the patient should be treated with steroids. Finally, a brief wording about treatment of idiopathic hypereosinophilic syndrome. Again, the mainstay of therapy would be corticosteroids. Immunomodulatory or myelosuppressive agents are reserved for patients who are not responding to steroids as adjuvant steroid-sparing therapy, and the recommended drugs are imatinib, immunomodulatory agents like interferon alpha, cyclosporine, and azathioprine, and myelosuppressive drugs like hydroxycarbamate. And there are 2 monoclonal antibodies, mepolizumab and alemtuzumab. So I have discussed about a lot of causes of eosinophilia, primary causes, secondary causes, and idiopathic. Apart from that, there were some atypical cases available in literature. As I have already mentioned, a patient with asthma with marked eosinophilia, patients with eosinophilic ascites, eosinophilic arthritis. And interestingly, there were several other atypical cases reported from Sri Lanka, like acquired platelet dysfunction with eosinophilia, myocardial infarction with eosinophilia, which was described as a variant of Cooley's syndrome, heart failure secondary to eosinophilic myocarditis in a young female, and there was a case of tropical pulmonary eosinophilia described in 2018, eosinophilic meningitis, and there was a recent case report on Kimura's disease mimicking eosinophilic granulomatosis with polyangiitis. So ladies and gentlemen, eosinophilia is not always about parasite, allergies, and drugs. It's a lot beyond that. So this concludes my presentation. Take-home messages would be patients who are asymptomatic, otherwise well, with mild eosinophilia, account less than 1,500, may not require further testing. However, it's very important to take a thorough history to examine the patient and to find an underlying secondary cause and to treat it then and there. Then patients with systemic symptoms or patients who are having persistently high eosinophilia, moderate to severe, account above 1,500, should be considered for aggressive evaluation and treatment. And in any case of eosinophilia, it's very important to find the cause, and concomitantly, eosinophil-associated end-organ damage should be evaluated. And finally, patients with an eosinophil count above 1,500 per microliter without any obvious secondary cause should be evaluated for a hematological neoplasm with clonal eosinophilia. So coming back to my case scenarios, the first patient was Mrs. X, a young female who is asymptomatic and having a eosinophil count of 900 per microliter. So this patient is asymptomatic. So the patient is not having eosinophil-mediated end-organ damage. So aggressive treatment with steroids is not recommended. But however, the patient is having mild eosinophilia, which is less than 1,500. So this patient does not need aggressive evaluation or treatment, but you have to exclude secondary causes. And if there's no cause, you can repeat the full blood count, maybe in 1 month's time, and follow this patient up and reassess and try to find a cause. The second patient, Mr. A, was a middle-aged male who had systemic symptoms. This patient has dermatological involvement, visual involvement, and cardiac manifestations with an eosinophil count above 1,500. So this patient should be aggressively treated with steroids because the patient is having end organ damage. And at the same time, the eosinophil count is above 1,500. So this patient needs aggressive evaluation to find the primary or secondary cause. And the third patient, again, Mrs. White, is a young female, asymptomatic, coming with an eosinophil count of 1,600 per microliter. This patient is having a count above 1,500 in contrast to the first patient. So this patient should be aggressively evaluated for an underlying cause, particularly primary cause, a clonal eosinophilia. However, since the patient is not having evidence of end organ involvement, aggressive treatment with corticosteroids is not recommended. So that's the end of my presentation. These are the references I used. Thank you. I would like to thank my trainers, Dr. Kumudini Jayasinghe and Dr. Tamara Kanangara from National Hospital Kandy for all their support and guidance. And in addition, I would like to thank my former trainers, Dr. Keith Kudaratna and Dr. Sunil Boathuge from National Hospital Kandy for their guidance and support throughout. Thank you.
Thank you, Sandika, for the presentation. It's open for questions.
Thank you. Actually, I forgot to congratulate the previous speaker for an excellent presentation. Coming back to your one, only in the last slide I saw you the tropical pulmonary eosinophilia. Is it something now people don't talk about it? And you said it was reported in 2018.
Yes.
But we are right to right you only have been diagnosing and treating tropical pulmonary eosinophilia. What are your thoughts on that?
Yes, so there have been patients with tropical pulmonary eosinophilia, but in available literature case, I came across only one case report reported from Sri Lanka. Actually, there are other case reports from elsewhere.
And also, is there any place for Eosinophil treatment? Eosinophil. This again supposed to be in the well treatment, but we don't do that.
Yes, like if it's a parasitic infection, there's a place, but if it's any other condition, there's no place actually. You have to treat the underlying cause.
And what about filariasis? One slide you just mentioned.
Yes.
Those days pain was not proven. Filariasis as a cause of eosinophilia.
Yes, it has been reported as a cause of eosinophilia. I didn't elaborate on that area.
Yeah, thank you for the very comprehensive lecture on eosinophilia. It's I find in my interpret the most common cause is the parasitic infections with venom. That's probably the most cause. So do you think that you advocate in investigating the extensively about patients who got the topic asthma? First give them treatment and see whether they work. If you advocate that, I mean, it's a practical. I do that very commonly because I give them treatment and I find that people are not serious. I don't even, and you didn't mention about testing for hospital antibodies or plasmosis and antibodies because there were common cause of Sri.
Yes, sir. So in patients with mild eosinophilia, as you said, we can go ahead with treatment and diagnosis.
Okay, thank you very much. The presentation again and answer the questions and just there to collect your conversation.